morning, doctor.
Hi. Good morning, young man. Have a seat, please. Based on your file, it seems that I haven't seen you for the past 2 years. How is asthma doing?
Perfect, sir. You know that I was diagnosed as mild persistent bronchial asthma of seasonal allergic type 3 years back. It was discovered that I am allergic to smoke and molds. During the first year, I was hospitalized 3 times. You asked me to start Singular 2 years back, and since then I never been hospitalized. Today I am coming for general follow-up. Actually, I have one question. As long as I doing great over the past 2 years, do you think that it is okay not to come back for follow-up unless I feel something?
Well, hospitalization history alone is not enough to make a decision. There are other things I need to know about before answering this question. Let me ask you some questions, have a quick examination, then I will tell you the future plan.
Sure, sir. Let's start. I am ready.
According to the International Asthma Guidelines, even if a patient is in very good asthma control, it is important to assess asthma control every 6 months. Asthma control is the degree to which the manifestations of asthma, symptoms, impairments, and risk are minimized and the goals of therapy are met. Asthma control can help guide decisions to maintain or adjust asthma therapy for this patient. While asthma severity describes the patient's intrinsic intensity of disease, asthma control is based on the intensity of disease and the appropriateness of asthma management. Rules to remember. It is possible that a patient with very severe asthma can still have well-controlled asthma. Likewise, a patient with very mild asthma can still have very poorly controlled asthma. Asthma control is not only based on recent hospitalizations. Components of asthma control include frequency of symptoms, nighttime awakenings, interference with normal activity, use of short-acting beta agonists, and forced expiratory volume. It's also important to consider exacerbations in the last year, loss of lung function, and treatment-related adverse events. Behind me, you can see the table that include the parameters that we depend on during asthma follow-up. Based on what we've got, and considering the international guidelines, I would like to see you once every 6 months for follow-up, or earlier in case something happened.
Okay, sir. Thank you.
Now friends, I would like to give you some recent up-to-date bullet info about asthma, that I think it is helpful for you. Let's go. Exam trick? Childhood asthma appears to be increasing in prevalence, despite considerable improvements in our management to treat it. 80% of all asthmatic patients onset prior to 6 years of age. However, of all young children who experience recurrent wheezing, only a minority go on to have persistent asthma in later childhood. There are 2 common types of childhood asthma based on natural causes. First, recurrent wheezing in early childhood, primarily triggered by common respiratory viral infections, usually resolves during lower school years. Initiated mainly by T helper cell type 1. Second type is chronic asthma associated with allergy that persists into later childhood and often adulthood. Initiated mainly by T helper cell type 2. If both parents are asthmatic, the risk is 60%. For a child with only one parent with asthma, the risk is estimated to be about 20%. If neither parent has asthma, the risk is 6% to 7% for the child to be asthmatic. There is a known correlation between levels of air pollution and lung disease, but the association between air pollution and asthma is less clear. Increased obesity and BMI may also be associated with increased asthma severity. Earlier menarche appears to increase the risk of developing asthma in young adulthood. In addition, both forced vital capacity and forced expiratory volume in 1 second are lower among women with earlier rather than later menarche. Recent data proven that either acetaminophen or brufen medications, in usual doses, for the relief of fever or pain in young children will not lead to worsening of existing asthma. In addition, exposure to antibiotics in infancy was not a major risk for the development of asthma. Maternal vitamin D intake is protective for the occurrence of asthma in the offspring. Delivery by cesarean section may increase the risk of childhood asthma compared with vaginal delivery. Also, the rate of asthma was higher in children with neonatal jaundice than those without. The presence of a wet cough or sputum production, finger clubbing, or pore growth suggests a condition characterized by chronic infections such as cystic fibrosis or bronchiectasis. Last but not least, often, response to treatment is the most helpful investigation. This can be assessed if necessary by measuring the PEFR before and after inhaling a bronchodilator. It should increase by more than 10 to 15%.